to start our monthly scientific activity. Today we will have a pediatric anesthesia day, and I would like to thank all the members of the pediatric anesthesia department, Professor Dr. Azza Azza, Dr. Amal Abu Laila, Professor Dr. Muhammad Farouk, and Professor Maha Jamil, and all the speakers that they are going to enrich us with a full diet of pediatric anesthesia. Let's to start with the first speaker.
Good afternoon, everybody. I would like to present Professor Dr. Lecturer of Anesthesia, Dr. Khaled Sarhan, Cairo University, and he's going to present a lecture titled Anesthesia for Pediatric Minimally Invasive Surgery. Would you please start?
شكرا دكتورة مها. شكرا دكتورة أمل، شكرا دكتورة مها، شكرا دكتور سعد، شكرا كل القائمين على اليوم العلمي. الحقيقة أنا دايما ببقى مبسوط إني أكون معاكم في البيجا أونلاين أسوسيشن. بسم الله الرحمن الرحيم. My name is Khaled Sarhan, lecturer of anesthesia, surgical intensive care and pain management in قصر العيني Cairo University. And my topic today will be anesthesia for pediatric minimally invasive surgery. Okay. To start with, what is the minimally invasive surgery? Minimally invasive surgery is a surgical technique that aims to overcome the morbidity and the limits of the conventional open surgery. However, and the term of minimally invasive surgery usually restricted to the thoracoscopic procedures and to the laparoscopic procedures. However, the term minimally invasive surgery is really an informal and maybe a marketing term, not rather than a technical term. That because, in fact, it may need more invasive monitoring equipment and skill. If we look at this setup, we can see that it is not a minimally invasive anyway. Okay, the history of the minimally invasive surgery. 1985, Eric Muet described the first laparoscopic cholecystectomy, and it takes about 10 years to be a standard of care in the laparoscopic cholecystectomy. I mean, to be a standard of care in surgeries. However, the pediatric minimally invasive surgery developed very slowly. That's due to the technical issues and resistance of the pediatric surgeons. 1991, Holcomb et al. Described the first laparoscopic followed by in the same year by Allen et al., who reported the first laparoscopic pyloromyotomy the same year. And after this start, 1995, there was a great development of the issuing of the International Pediatric Indosurgery group. And in the same year, it was the first issue of the Journal of Pediatric Indosurgery and Innovative Techniques. When I searched for the pediatric minimally invasive surgery today on the Pubmed, I have found about 26,000 or more than 26,000 of publication about the pediatric minimally invasive surgeries, and more than 2,000 publication the 2020 in the year 2020. This is a small part of the very long list of the minimally invasive surgery procedures that can be done in pediatrics. So what are the advantages of the minimally invasive surgery? It seems, does it worth doing such large operations with a tiny incision? It seems it's not just about the cosmesis. It's more and maybe larger than cosmesis. Yes, the scar is a small scar and maybe invisible after a few months. However, it has less pain and less incidence of dehiscence and herniation and less infection risk. In fact, the minimally invasive surgery can act as a perioperative site infection. If you look at this study, we'll find that the surgical site infection in the laparoscopic procedures is much lower than the open procedures, and the odds of having a surgical site infection have been reduced throughout the whole procedures done using a minimally invasive surgery. Also, the chest wall deformity, the incidence of chest wall deformity after thoracotomy, the conventional thoracotomy procedures reaches about 30% of patients undergoing thoracotomy. If we look at the chest X-ray, we can see a marked angulation of the spine only 8 months after a right thoracotomy. This incidence is much less in the minimally invasive surgery rather than the conventional surgery. Also, we have intra-abdominal advantages, like the better visualization of the obscure structures and areas, like the for example, the lower esophageal sphincter complex and the small vagal nerves. And it may reduce the post-operative adhesions. It has a great help in the diagnostic issues when the diagnosis is a little bit obscure, and it allows a yearly post-operative feeding and less hospitalization, and as well less cost. In 2002, the laparoscopic appendectomy was seen as an unnecessary and expensive procedure to be done in children. However, now it is the favored and the recommended technique over than the conventional technique in Europe. And perhaps in the next few years, we can see it as a standard of care like the laparoscopic cholecystectomy in adults. However, we have some challenges to the minimally invasive surgery in pediatrics. First, the speed. The minimally invasive surgery and its relation to the operation time is mixed. Sometimes it may take less than the time needed by the standard procedures in laparoscopic pyloromyotomy, for example. However, in some times it may take much longer times rather than the conventional techniques like the Kasai porto enterostomy in biliary atresia procedures and congenital diaphragmatic hernia, TOF repair, and so on. The time factor here is very important. It's not just increasing the time of surgery. However, the prolongation of the time have many consequences. First, it may decrease the post-operative body temperature significantly if we have a longer duration rather than 1.5 hours, especially in the neonates. It may result in increase in the peak inspiratory pressure, and the frequency of incidents like hypotension, hypoxia, and severe hypoxia, bradycardia, and hypothermia. The incidence is much higher if the surgery procedure is elongated. And also the frequency of post-operative intensive care and the need for post-operative intensive care is also increased if we increase the time of the minimally invasive procedures. And so the clumsy minimally invasive technique, it's not a minimally invasive anymore. It may be a maximally invasive procedure. We have also some technical issues as a challenge to the minimally invasive surgery, like the instrumentation. We have, despite the development of such great, such small and very fine instruments like 2 and 3 millimeter instruments, and the innovations of the video technology and high resolution technology, we have still some issues regarding the small infants and the neonates. It is as if we are going to make a ship into a bottle. Other challenges to the minimally invasive is the reducing the working volumes in the chest or the abdomen in the small infants and neonates. We have a very tiny volume, so we need a very fine movement, and also the dissipation of energy can be dissipated unintentionally to the adjacent structure in the small volume. If we look at this picture, we have a 3 kilogram infant undergoing a thoracoscopy procedure. Here, the working volume is about 35 to 40 cubic centimeters, which is smaller than a golf ball. So we have a very small working volume here. Another big challenge is the hypothermia. It may seem that the minimally invasive can protect the patient from hypothermia, and this is a wrong, a wrong fact. It's not a fact. It's actually, we have a hypothermia more in the patients undergoing minimally invasive surgery rather than the conventional surgery. This is because of the insufflation of CO2 gases that cause a drop in the blood, in the temperature of the children, and especially the small children and neonates. For example, if we have a 4 kilogram infant, the dry gas flow at 6 to 8 liters per minute can create evaporative cooling that consume about 40% of the infant metabolic power. This is much lower in the adult. So it is not, the problem is not evident in the adult rather than in the small infant and in neonates. And under the anesthesia, we have no mechanism for raising the metabolic rate to match these losses, and so hypothermia occurs, and especially if we increased the duration of surgery. Here we can see a linear relationship between the postoperative hypothermia and the length of the procedure. If we increase the length of the procedure, the hypothermia will occur surely. We have some solutions for the hypothermia, like humidifying the insufflated gas and reducing the amount of gas that leak from the instruments, and reducing the flow of the insufflated gas, and for sure trying to decrease or to the time needed for surgery. The second challenge is hypercarbia. The minimal invasive decrease CO2 elimination and results in hypercarbia by 2 ways. First, increasing the CO2 load by absorption. About 10 to 20% of the CO2 during the pneumoperitoneum is absorbed, especially in the infants and neonates. And the other mechanism is reducing the minute ventilation by restricting the tidal volume due to compression over the diaphragm. The anesthesiologist's ability to compensate for this limitation of the abdominal movement is by increasing the peak inspiratory pressure, and this might increase the risk of parotrauma. Infants require not only a higher baseline respiratory rate, but disproportionately larger increase in the respiratory rate than adults to compensate for insufflation. If we look at this graph, we'll find an exponential relationship between the respiratory rate and the in-tidal CO2. There is an exponential. We have to increase the body mass index. If we decrease the body mass index, as we can see, we have to increase the respiratory rate very much in order to maintain a steady state of carbon dioxide. We can reach up to 60 respiratory rate up to 60 per minute in order to maintain the steady state of carbon dioxide. What are the physiological responses to raised intra-abdominal pressure? The intra-abdominal pressure is a major determinant of the cardiorespiratory change that occurred during laparoscopy. The cardiac change, there is a decrease in the cardiac output as a result of the decrease of the venous return and the increase in the systemic vascular resistance after insufflation of the abdomen. There is also a reduction in the preload that can result in decrease in the initial decrease in the blood pressure. Usually, these changes have no clinical deleterious effects in the healthy infants, and they are completely reversible after peritoneal decompression. Also, we have, as in adults, the reflex bradycardia, the vagally mediated reflex bradycardia that may occur even up to asystole that can occur during insufflation, especially in the infant and small children. And so prophylactically treatment by atropine or glycopyrrolate is maybe important in such population. If we look at this study published in the British Journal of Anaesthesia about the hemodynamic change during laparoscopic herniorrhaphy in the small children, they have 8 small children having laparoscopic herniorrhaphy, and they insufflated the abdominal pressure by 12 millimeter mercury, and then they reduced to 6 millimeter mercury, and then they regained to 12 millimeter mercury, and they watched the effects on the cardiac index. They found that the cardiac index decreased significantly only in the first 12 millimeter mercury level of increase of intra-abdominal pressure. However, this increase was not clinically, this decrease was not a clinically significant reduction in the cardiac index. And this drop in the cardiac index returned back to normal when the subsequent, the intra-abdominal pressure subsequently decreased to 6 millimeter mercury. And so we can conclude that the intra-abdominal pressure of up to 12 millimeter mercury is appear to be safe in healthy small children. The respiratory changes. Respiratory changes in infants, there is a reduction of the functional residual capacity due to raised intra-abdominal pressure, causes alveolar collapse, and increase in the VQ mismatch and oxygen desaturation that occur more rapidly than in adults. In this study published in the Pediatric Anaesthesia, they have 19 children or infant less than 1 year, and they saw the effect of the insufflation pressure on the pulmonary mechanics in those infants undergoing laparoscopic surgical procedures. And they found that there is an 18% increase in the peak inspiratory pressure, and there is a up to 33% decrease in the tidal volume if they insufflated the abdominal pressure up to 12 millimeter mercury if the infant is less than 5 kilograms, and if they insufflated the abdomen by 15 millimeter mercury if the infant's body weight more than 5 kilograms. They found also that the compliance decreased by almost 48%, and the end-tidal CO2 increased by 13%. The challenges to the thoracoscopy, especially in neonates, the neonates are more sensitive to thoracoscopy rather even than the laparoscopy. The same change that occur during laparoscopy, and we can add that the pneumothorax required a ventilation with a higher fraction of oxygen due to the VQ mismatch that frequently occur, and also the hypotension and that frequently occur and need a frequent vascular expansion in such a population. Also, the direct pressure on the lung and the heart may impair and more extensively the gas exchange and the cardiac output, resulting in significant hemodynamic changes. Also, the surgical indication for thoracoscopy, like tough procedures, may also be an aggravating factor because part of the ventilation is lost through the fistula, the tracheoesophageal fistula, which is not yet closed. And also, the chest condition, the bad chest condition of such population may impair or we have an underlying VQ mismatch already. Also, the lung isolation technique in such neonates is difficult and technically challenging, and so also the length of the procedure. Usually, it's more or less a lengthy procedure, and so it is a challenging procedure. So we have to pick up the population or the neonates that are at risk for the insufflation-related incidents. We can say that the procedure, if they are longer than 1.5 hours, they put the neonates or the small infants at risk for insufflation-related incidents. Also, the initially low body temperature and the higher insufflation pressure needed, and the intidal and as well intidal CO2 variations. If we need a vascular expansion and need a vasopressor for such infants, this may increase the risk of insufflation-related incidents. If we need a major modification in the FiO2 or the peak inspiratory pressure at the start of insufflation, this may point out that this neonate may be at risk for the insufflation-related incident. Okay, what about the management of anaesthesia for a laparoscopic procedure in infant? The preoperative, we have to do a detailed history and physical examination to identify the underlying medical condition. Usually, the preoperative laboratory investigation, hemoglobin and hematocrit, usually sufficient for most of the procedures, because usually these procedures are, having low blood loss and minimal blood loss usually in such procedures. However, if the baseline hemoglobin is low, and if we have a complex surgery and a major procedure that there is a possibility to do even laparotomy procedure at once, we have to take a blood sample for grouping and cross-matching. The pre-medication, the anxiolytic and sedative pre-medication is very useful in such small infants and children to allow the easy separation from the parents. Atropine and glycopyrrolate or glycopyrrolate may be included in the pre-medication to prevent the reflex bradycardia during insufflation. Induction usually either by inhalational technique using sevoflurane or by intravenous induction, followed by a non-depolarizing neuromuscular blocker to facilitate the endotracheal intubation. Endotracheal intubation is a gold standard. However, it has been recorded a laryngeal mask airway use in such short laparoscopic procedures, and no negative consequences occur. Ideally, we use an IV line that is above the level of the diaphragm, because to avoid the consequences of increased intra-abdominal pressure, which compresses the IVC and can block the access of the drug and fluids to the systemic circulation. Usually, the maintenance volumes of fluids are required, especially if longer procedures are going on. The ventilation, we have to increase the ventilation by about 15 to 30% during the procedure to compensate for the extra load of carbon dioxide. Peak inspiratory pressure is usually needed to counteract the effect of increased intra-abdominal pressure on the functional residual capacity. Monitoring, we should include the 5 basic monitoring, and the temperature monitoring is very important in such procedure, especially in the lengthy procedure. The esophageal stethoscope may be useful in detecting air embolism. Invasive monitoring is usually not needed in such a procedure unless it is lengthy or a complex procedure. Peak inspiratory pressure should be watched carefully and closely. The intra-abdominal pressure should be limited to be between 5 to 10 millimeter mercury in the infants and 10 to 12 in older children. lower insufflation pressure is needed for sure in thoracoscopic procedures. 4 to 6 millimeter mercury usually is needed. The dependence on the end-tidal CO2 may be inaccurate, especially in neonates and especially in the long procedure. And so if we are expecting a long procedures, ABG is usually needed to avoid in the lengthy procedures to avoid the inaccurate end-tidal CO2 results. The measures to prevent the perioperative hypothermia, we can increase the temperature of the operating room to 25 or 26 degrees centigrade and humidifying the inspired gases using an active heating plank, forced convective air heating system, or an infrared radiant heater, and warming the solution used for intraoperative irrigation, and for sure limiting the time of the procedure as we could. The postoperative analgesia, usually the multimodal approach is very useful by a combination of local anesthetic infiltration to the trocar site, trocar insertion site, or intra-abdominal installation of the local anesthetic, and use of the non-steroidal anti-inflammatory drugs plus or minus opioids, usually sufficient. Caudal epidural also has been demonstrated effective following the laparoscopic procedures if it is below the level of the umbilicus. And lately we have the fascial plane blocks, TAP blocks, and other fascial plane blocks, and it is a very helpful and effective procedure for pain management. The postoperative nausea and vomiting is a common, especially after laparoscopic procedures, especially in older children more than 3 years of age. So these incidents can be reduced by use of prophylactic use of the antiemetic agents. And thank you.
Thank you, Dr. Khaled, for this very important topic. Shall we open a discussion only for 5 minutes, please? If anybody wants to ask Professor Dr. Khaled about his lecture. Dr. Khaled, I only have one point. I would like you to give me an answer about it. What about brain oxygenation in these cases? Several researchers are targeting the effect of minimally invasive surgery on cerebral oximetry, especially that INVUS is, or the NIRS, is becoming a popular non-invasive monitor. Do you recommend using laparoscopic surgery in neonates after the era of INVUS in our practice?
Thanks, Dr. Amal, for the nice question. I have read some of publication about the effect of insufflation, intra-abdominal, increased intra-abdominal pressure and insufflation, the effect on the cerebral oximetry. And it has found that the cerebral oximetry decreased significantly in such population. However, in the era of the cerebral oximetry, we still don't have guidelines that recommend when to interfere if the cerebral oximetry decreased, or I mean, we don't have a target point to act upon if we have a drop in the cerebral oximetry. Also, we don't have a study that shows an post-operative long-term, I mean, long-term post-operative effect if the cerebral oximetry dropped during the procedure.